Hello, good morning, everyone. Thank you for coming to the multi-energy CT session for GI. My name is Benjamin Ye from UCSF, and it is my pleasure to open the session. Our first speaker will be Barry Dang from NYU, who needs no introduction. She'll be talking about interpretation of abdominal pelvic dual energy CT in clinical practice.
Oh, I see. Okay. Thank you for the introduction. So before we talk about dual energy CT in practice, I want to just briefly review some of the dual energy CT reconstructions that we'll be discussing. So we have to start with the virtual non-contrast. So this is created from a contrast-enhanced data acquisition, the same data acquisition with no additional radiation to the patient. So instead of scanning the patient pre- and post-contrast, you scan them one time post-contrast and get that virtual unenhanced image for free. So we build this into a variety of our protocols at NYU, the multi-phase protocols, and it's really helpful for incidentaloma characterization. Think of those adrenal adenomas and renal lesions. So next I want to talk about an iodine overlay. This is a color iodine map which is superimposed on a grayscale virtual non-contrast image. And I think of these in the same category as the iodine maps. Just when we implemented dual energy at our practice, we started sending these iodine overlay images to PACS, so I have a number of those kind of cases. So material decomposition, this is the principle that allows for generation of these images, and it takes advantage of a material's behavior at low and high kV to determine what it's made of. And I'll show you another clinical application of that in this talk. And finally, virtual monoenergetic images. These are created from a polychromatic beam, and it could be at a low KeV, closer to the K edge of iodine, so iodine looks whiter, or further away, which has more energy, helpful for overcoming metal artifact. So here's our outline of what we'll cover in the rest of this talk. And we'll start with virtual non-contrast. So as I said, you can build these virtual non-contrast images into your protocols. And here's an example where the patient had an exam on our dual energy scanner on the top. So this is a virtual non-contrast, whereas they also had this CT angiogram on the bottom on a conventional CT scanner. So this is a true non-contrast. Diagnostically, I think pretty similar. I feel equally as confident on both. And you could see, maybe you can't, but we gave the same intravenous contrast volume on both of these scans. Sorry, you couldn't see my mouse. The top is the virtual non-contrast. And just subtracting that true with a virtual non-contrast resulted in greater than 50% radiation exposure. So this has been studied, and one study showed that there was 100% of endoleaks were diagnosed with a virtual instead of a true non-contrast, and there was 44% radiation exposure reduction. So you can do it and reduce radiation. So here's another common scenario. This is a patient who has lung cancer and a 77 Hounsfield unit left adrenal nodule on this post-con CT. And we don't have any priors at our institution. So on this study, we would have to interpret this as adenoma or metastasis, and the patient would get a follow-up study. But you can do better. So here's the virtual non-contrast showing it to be 5 Hounsfield units, and this is an adrenal adenoma. And it has been shown that there's substantial diagnostic agreement between the virtual and true unenhanced images for differentiation of these lesions. So here's another example. A patient with iron deficiency anemia had a single-phase CT enterography, and you can see that there's layering hyperdense enteric contents. So is this a GI bleed? Well, fortunately, it's on our dual energy scanner, and you can see those hyperdense foci persist. And this is not a bleed, it's hyperdense enteric contents. So something that I like is that these virtual non-contrast images, they're the same acquisition. So it's a lot easier, particularly for looking at bowel, whereas a true non-contrast, things will move between the images. So here's a companion. We have an axial arterial phase image showing a curvilinear hyperdense focus in the ascending colon, which is not present on the virtual non-contrast, is present on the iodine overlay. So even though it's pretty subtle, you're very confident that this is a GI bleed, which was confirmed on a subsequent conventional angiography. So how do we do for GI bleeding? So here's a study comparing Protocol 1, which had a true non-contrast, and Protocol 2, which had a virtual non-contrast. And you could see that while there's trends towards improved diagnostic performance with dual energy, with the virtual non-contrast, that didn't reach statistical significance. But there was a 30% radiation exposure reduction, so similar diagnostic ability, but less radiation to the patients. Last example in this category, we have an axial portal venous phase image in a patient with breast cancer, which looks normal to me. But if you look at the virtual non-contrast from the same acquisition, you can see these metastases, which you can't see on the portal venous phase because we know sometimes breast cancer metastases can be isodense. So this is a nice application of virtual non-contrast images. Okay, so next, the iodine overlay. So here's an axial portal venous phase CT in a patient with known portal vein thrombus being treated with anticoagulation for follow-up. And you can see the arrows pointing to an expanded main portal vein with a filling defect. So ongoing portal vein thrombus, next case. Well, here's the iodine overlay, and you can see that there's quite a bit of color within this thrombus. It has an iodine density of 1.7, and it has 44 Hounsfield units enhancement. So this is actually enhancing tumor thrombus. It's not bland, and it was until this dual energy CT that the patient was clearly being completely mismanaged. So after this CT, they biopsied the thrombus, and it was an acinar cell cancer of the pancreas. So here's a companion, a 27-year-old woman who presented with acute pelvic pain to the ER. And this was interpreted as a large pelvic mass with ascites and peritoneal thickening compatible with carcinomatosis, and the patient was seen by gynecologic oncology and planned for an extensive tumor debulking surgery. But the iodine overlay was overlooked, and you can see that there's actually no color within this mass, and this mass is in fact a hematoma, explaining the patient's pain and allowing avoidance of an unnecessary surgery. So based on that data I showed you earlier, we don't use a true non-contrast, we use a virtual non-contrast for our endoleaks. So here we have an arterial and venous phase image that we acquired for endoleak assessment. And this is the finding, which I have to be honest was overlooked by the trainee on first interpretation. But if you look at here on the iodine overlay, you see it's really quite a bit more obvious when you look at the iodine overlay. Really a subtle finding on the conventional images. And again, on the virtual non-contrast on your right, you can see that it's not present. So this is an endoleak. So last in this category, this is something near and dear to my heart. We have a coronal image from ACT enterography with intravenous and neutral oral contrast. And you can see that the terminal ileum, it does look to be narrowed. It has a stratified appearance. Maybe you're not sure it's active or not. You could look at the iodine overlay. You can see here it's brighter in color than the rest of the bowel, so you think it's active. But you can also draw region of interest measurements and see that the iodine density is 4.4 milligram per milliliter, 50% normalized to the aorta. And we found that 2.6 milligram per milliliter was a threshold for active inflammation using the Crohn's disease activity index, and a 20% iodine density threshold. So this number had 100% sensitivity and 92% accuracy for active histopathologic inflammation. So this is something that we're doing daily in our routine practice at NYU. Okay, so now an application of material decomposition would be determining the composition of kidney stones. So there's various types of kidney stones, including calcium stones, which are most common, and these are treated with shockwave lithotripsy, uric acid stones, which are treated with oral medical therapy, maybe cysteine stones, which are actually pretty shockwave lithotripsy resistant. So using the dual energy ratio, which is the ratio of the attenuation at the low and the high kV, you can determine what the stone is made of. So here's an example. On your left is a non-contrast CT showing a right renal pelvis stone. Qualitatively, of course, you can't tell what the composition is, but you can see the dual energy ratio is 1.83. It falls here on our material decomposition diagram, so we know this is a mixed calcium stone, and this could be treated with shockwave lithotripsy. Whereas this patient, here's a non-obstructing left lower pole stone, although other than the size, qualitatively, you can't really tell the difference. But the dual energy ratio is quite different. It's 0.9, and it falls here in the uric acid portion of this material decomposition curve. And if necessary, this patient would be treated with oral medical therapy. So dual energy CT directly guiding patient management, and this is supported in the literature. So finally, virtual monoenergetic images. So as we know, iodine has a K-edge. Closer to that K-edge, lower KEV makes iodine look brighter. So here's a conventional image, and it shows a mass between the stomach and the pancreas. And it really is difficult to tell where it's coming from. If you biopsy it, it'll be a tumor, an adenocarcinoma of gastrointestinal origin. But that doesn't really help with your chemotherapy regimen and the like. So here's a low KEV image from the same location where you can see the yellow arrow is pointing to this tiny vessel arising from the left gastric artery, which allowed this to be localized as a gastric adenocarcinoma. And you can't see that small vessel on the conventional CT image. So these low KEV images can be used to increase small vessel conspicuity. So here's another example. We have a coronal image from a CT with intravenous and positive oral contrast. You can see that there's dilated fluid-filled small bowel feces sign, and then collapsed distal small bowel. So this patient hasn't had prior surgery, so it's not an adhesion, really nowhere near a hernia. So what is causing this obstruction? Well, here's the commercially available iodine overlay, and you sort of get the hint that there's something there. If I zoom in for it, this is a little oblique. You can actually see it looks like there is something there. It's enhancing. And here's the low KEV image where you can see this tiny neuroendocrine tumor, much better than on the conventional image. And this was prospectively accurately diagnosed using dual energy CT. So these low KEV images also improve the conspicuity of hypervascular foci. So since you can see contrast better, you can also give less contrast. So here's a 30 cc angiogram. If you look at the low KEV image on your right, you can see there's excellent attenuation of the aorta, and this is well documented in the literature. So it's not just hypervascular lesions, so low contrast visibility areas like the liver and the pancreas really benefit from these low KEV virtual monoenergetic images as well. So here's a heavily windowed image through the pancreas, and it shows a pancreatic body mass. But if you go to the low KEV, you can really see it more clearly on its borders. And this ability to see these tumors more clearly on low KEV images is documented in the literature. On the other hand, the high KEV images can be used to overcome metal artifact. So on your left is a linear blended image, so similar to that conventional 120 kVp scan. And you can see quite a bit of artifact emanating from the left hip implant, which is markedly reduced on the high KEV image. So that's it for interpretation of dual energy CT in clinical practice. We talked about virtual non-contrast images, iodine overlay, kidney stone characterization, and virtual monoenergetic images. And I hope I've shown you that dual energy CT can save radiation. You can replace a true non-contrast with a virtual non-contrast. It's really helpful for problem solving. Think, is the lesion enhancing or not? And doing so, you can avoid an unnecessary follow-up study, and in doing so, it will save some money. So that's it. Thank you for your time and attention.
Thank you, Barry. I always feel comfortable when we see a dual energy scan come up because I know that we have so many useful tools that we can use. So thank you, Barry, for that awesome presentation. Our next speaker is Al Silva from Mayo Clinic in Arizona, who will talk about implementation of dual energy CT in clinical practice.
Thanks, Ben. My disclosures. So just for kicks, I went ahead and asked ChatGPT if I could give this talk in 11 minutes. And you know, ChatGPT can be pretty encouraging because it said, no, I don't think you're crazy for trying to give a talk at RSNA on implementing dual energy CT into clinical practice in only 11 minutes. But you know, it actually added this. It said, I think you are ambitious, passionate, and confident. Wow, ChatGPT kind of gets me. But you know, there is some humble brag in ChatGPT. It also said, you have also asked me for help, which shows that you are open-minded and willing to learn. I admire your courage and enthusiasm. I believe you can do it. And it actually added this smiley face emoji to it. So with all that, challenge accepted, and let's go. So from a show of hands, how many have a dual energy CT scanner, at least one DECT scanner in your practice? So a fair number. So keep your hands up if you think you're using it optimally. Okay, so basically, okay, yeah, we always have some in the crowd that keeps their hands up. But nevertheless, you guys aren't alone. This was a survey done by the Society of Thoracic Radiology where 75% of the respondents answered that they do have a dual energy CT scanner, but it was not being universally used. There were various reasons for that, including radiation dose concerns, perception on image quality, and complex workflows. But this is not just a domestic issue, it's an international one. This was a survey from the UK where 72% of the respondents said that they had dual energy CT scanners, but again, it wasn't being used optimally, and a lot of the issues were lack of experience with dual energy CT, as well as availability of suitable protocols. So I did an informal, non-scientific survey trying to figure out what were the reasons for people not using dual energy CT, and it basically boils down to the three big categories, and we're going to tackle those. So under myths and misconceptions, if you weren't here at this talk and saw that excellent talk, there are questions about radiation dose and then as well as poor image quality. Well, if you look in the literature, there are studies that say that dual energy CT has poor spatial resolution, motion-related artifacts, and increased noise. But those were really older studies. The newer generation CTs, because of advanced imaging and software and hardware, now at that time, this was kind of in the early 2000s, there was an emphasis to try to make these scans dose neutral to conventional CT images. And now, as you saw, these newer third generation scanners can actually decrease radiation dose. This was a study that showed that they were able to decrease radiation dose by approximately 58% in matched single energy CT cohorts. So that was radiation dose. Radiation really is not necessarily a concern for not using dual energy CT. What about image quality? Well, that image on your screen right is not an image I would like to read. It's noisy, has poor contrast, and these are some of the reasons people are hesitant about using it. Oh, wait a second. That's actually the single contrast image. And yes, this is a large patient, and of course we don't have great image quality, But I want you to pay attention to the dual energy CT scan because this is not a simulated 120 kVp image. In fact, if you can see, there's some artifact here peripherally. This is the iodine display. And so this patient, and this is the image quality that we are able to get now. And just for reference, here's a second generation iodine display previously. So what about workflow, issues with workflow? In general, when a patient gets a request for a CT scan, they go get scheduled on the next available scanner, and then a protocol gets placed. The issue with this is if you have both single and dual energy CT scanners, then that patient may get scheduled on the inappropriate scanner. So what we need to do is we actually have to move that protocol before they actually get scheduled. So there's a couple of ways to manage that. You can actually use the exam type and say, for example, any CT urogram will take advantage of dual energy CT. We'll just route those to dual energy CT scanners. You can also specify clinical indications. For example, if a patient's going to have rule out PE, and then those could be routed to the dual energy CT scanners. So then now you have to actually have a dual energy CT protocol. And you can certainly do that yourself and start from scratch, but you can also leverage the work that's already been done. There's a plethora of guidelines in the literature. This was a multi-institutional consensus paper that discussed best practices for which series and protocols to use for dual energy CT. And this is for abdomen studies, but just do a little Google search and you'll see that this is on any organ system. So here's cardiac, neuro studies that have guidelines as well. So eventually what you'll want to do is train a CT tech, maybe your lead tech, to be your dual energy CT super user, because they're going to be able to really help the workflow. They can help the schedulers with triaging the dual energy CT studies, and then they should know the nuances of the protocol. Some protocols may take a little bit longer, so they can make sure that the scans are not scheduled back to back, so that's going to be very helpful. So eventually that's something I would recommend. So, and then here's a couple of papers that discuss that. So now you've scanned the patient, then those images should go to the scanner, right? So then we're done. Unfortunately, there's some additional post-processing steps with dual energy CT. So the data after the patient scan, then it should go to a independent workstation where the dual energy CT images are post-processed, and then it finally gets to the radiologist to read. So that's one way that this can be set up. The other way is that you could have a thin client where the data gets sent to, and the poor radiologist has to do their own post-processing. Neither workflow is really very conducive to a heavy and busy workday. So wouldn't it be great if we could just skip that middle step and just have the scans sent directly to the scans be automatically post-processed and then sent to the workstation? Well, that functionality is now available. So if that's not something that you're using in your dual CT workflow, then perhaps touch base with your vendor and see how you can incorporate that in your workflow. Okay, so now we've scanned the patient, we're sending it to the PAC station. Also, you do want to send it to an independent workstation or a thin client, so then if there's any additional post-processing that's needed, then that could be done as well. Okay, so then what's the elephant in the room? Well, the question or the issue is that these exams take time that we don't have, or they're too many images to read. So a lot of this is basically, to solve that would be education. And then you already saw a great talk on how the benefits of dual energy CT. With respect to data overload, one of the things you want to do is you want to optimize those protocols and minimize some of the redundancy and only send those necessary images to PACS. So for example, let's take a look at this triphasic CT. That already gives you 3 series. And then if you add all the dual energy CT displays that our first speaker mentioned, that really now balloons to 12 series. But as I alluded to earlier, we don't necessarily need to have those, that there are best practice guidelines on what to send to PACS and what's going to be important. And so instead of having 12 series, we can actually just bring that down back to 4. And in here, you still have your triphasic CT series. Now we're leveraging some of the information from dual energy CT, can add this quote-unquote free virtual non-contrast, and then you could also add the iodine display. So what about time? We're all busy. Well, we really should be leveraging our full functionality of our packs. What we shouldn't be doing is we're reading a single window where we first look at the arterial phase images, then the portal venous phase, and then the delay images. We want to set up multiple windows, align and sync your series, and then quickly be able to detect lesions and then compare and see and try to characterize those lesions. So this is a single energy triphasic study, but if we change that easily to a dual energy CT, then we can just add those dual energy CT images to replace the arterial and delay phases, and then tweak your hanging protocol a little bit, and then you can add those iodine and VNC images as well. If you're used to using a 3x2 display, then you can still just create it so that you're seeing all the dual energy CT information at once. So then now the last topic is radiology buy-in, and really this is education. So you could, if you had taped the first speaker's talk, then you could just send it to all your colleagues and say, this is the value of dual energy CT. I wanted to point out this one study where dual energy helped improve diagnostic confidence. This was a study that looked at over 3,000 emergency room studies, and they compared CT versus dual energy CT exams. And what they found was that the dual energy CT altered management, increased diagnostic confidence, and they were able to characterize incidental findings so that they could avoid unnecessary follow-up studies. Interestingly, the net overall cost reduction when they implemented this was over $60,000 in Medicare dollars. The telling part of this study was that the co-authors had a practice change in their group. They now do all their ED exams using dual energy CT. So I won't belabor this point because Barry did an excellent job at all the additional information that dual energy CT can give, either supplementary or even new that you're not able to see with single energy CT. But as I mentioned, there's a number of studies in the literature that can help with that. So in conclusion, it's the old adage for dual energy CT. It's not supposed to make your job harder, but help you work smarter. And continued innovations in hardware and software design really has mitigated issues with radiation dose and image quality. In terms of dealing with the image proliferation and data overload, we really want to optimize our protocols, use seamless workflows, and really leverage the way we're interpreting these studies. So again, the big elephant in the room is to get buy-in from our colleagues, but then we can show them how dual energy CT can help us with even just routine interpretation. So in groups that have successfully implemented dual energy CT, it really is helpful to have a radiologist super user, someone who can champion implementation and utilization. So all of you in this room, because of your interest, you can be that super user in your group and ultimately finally implement dual energy CT in your clinical practice. And with that, I'd like to thank you for your attention.
Thank you, Al. You always make it sound so easy. I always pick up a few tips from you about how to simplify our dual energy CT practice. It's my pleasure now to introduce Shuai Lang, one of the pioneers in photon counting CT, to teach us a bit about the principles of photon counting CT.
All right, thank you very much, Ben. So this talk, my colleague, Dr. Cynthia McCullough, is supposed to give this talk, but she told me she didn't feel well, so I'm sorry, very sorry about that. I will try my best to give this talk on the fundamentals of photon counting detector CT. Here are the disclosures. So I think we have heard a lot about photon counting CT in the last couple of years, and so I want to talk a little bit about how photon counting detector works. But before we jump into that, let's take a look what's our so-called conventional CT detector, how those works. These are so-called energy integrating scintillating detectors. So the way it works is The detector made up of some rare earths, usually rare earth ceramics, some scintillators. When X-ray comes in, interact with the detector material, it generates visible light. And this visible light will be detected by the photodiode and then being recorded as electric signal. The signal we collected here is proportional to all the photon energies. So basically we put everything together, all the photon together into one bucket. That's why it's called energy integrating detector. We don't have information about each individual photon, and in addition to that, because there existence of a visible light, it can go all the directions, and we don't want them to go all the directions because that lose the spatial resolution. So we put subtype in between. Those are dead space. We lose some of the geometry efficiency and dose efficiency. On the other hand, if we look at the photon counting detectors used on the photon counting detector CT nowadays, they use semiconductors usually. And the way it works is the X-ray directly interact with semiconductor, generate electron-hole pairs, and when it drifts towards the anode cathode, that generate the electric signal, and the signal we collected here actually proportional to the energy of an individual photon. So this time we count the individual photon instead of putting everything together. That's where the name comes from, photon counting. And because we don't have visible light any longer, we don't have the septa, so we can maintain very high dose efficiency without lose the dead space of there. So how photon counting detector work? This is a very simple, quick demonstration. Let's see, we have a series of radiation events, those different lengths, different height representing different energy. The photon counting detector allows us to set up a threshold. So let's see, we set the first one as 20 keV. So anything above 20 keV will be recorded. So we saw a few peaks will be counted. Then we can do this thing again with a higher threshold, say 65 keV. So you see now fewer peaks above of that. And this in CT, in the photon counting, we call this high energy threshold data. And the previous one, low energy threshold data. And on the commercial CT scanner we have now, you might see the word T3D. It's basically the low energy threshold to put all the photons above the 20 keV. It's very similar as a conventional single energy data. But because we have two measurements, we actually can manipulate between those two, do some operation. For example, we subtract between them. That give us so-called energy beam images. We have high energy beam. We have the low energy beam. So obviously, if we have multiple data sets, we can do more things than just one single data set. So that's the photon counting, how it works. The reason we are so interested in photon counting detector and invest so much time and energy is because the benefit it brings in. It can reject the electronic noise. It can increase the iodine CNR dose efficiency. It can increase the signal at a high keV, reduce metal artifacts, improve spatial resolution, lower radiation dose, and give us simultaneous single keV multi-energy CT with perfect spatial and temporal registration, and also provide the capability to do K-edge imaging, multi-contrast imaging, and possibly give us opportunity to look at new contrast agent. And I very much look forward to the later talks on this. So I will try to show a few of these. Of course, due to the time limit, we're not going to look at all of them, but I'll try my best to look at a few examples. So the first thing, eliminate the electron noise. Why can we do that? Very simple. The plot I showed here on the top right corner there, those bottom ones are noise. But if we can set up our threshold above that, then we don't count those. So it essentially eliminated the electronic noise. This is very important when we have low dose scan, we have large patient exams where the electron noise become more obvious. And this can, for example, can reduce the strict artifacts we see here. The other thing is increase the iodine SNR. Why is that? Let's take a quick look. So the spectrum we have is a broad spectrum. We have different energy photons coming in. In the conventional energy integrating detector, we give a lot of weight to high energy photons, right? Let's say we have two photons. One is 10 keV, the other 100 keV. The 100 keV will count like 10 times more signal than the 10 keV. But on the other hand, we also know our attenuation of signal is energy dependent. If we look at this iodine signal, the high energy actually give us less signal there. So this is like going opposite direction. This is really not efficient way to use our photons and the signal, especially with the K edge of iodine and 33 keV. On the other hand, photon counting give us equal weighting. So everybody is equal, 10 keV EV photon, 100 keV photon. Both of them considered as one photon, so they are the same. Then compared to EID, this effectively gave us better weighting and signal to the low energy photons, which give us better contrast. So clinically, if you look at the image, 120 keV EID on the left, 120 keV PCD on the right, the same patient, much brighter iodine signal and better image quality, as we can see here when we zoom in. So this is why it can increase SNR. Virtual model energy images, the previous two speakers highlight great benefits of those. So this is also possible with photon counting detector CT. This simulated images acquired with ideal monoenergetic beam, although our real beam never be monogenetic. So in addition, this gives us actually a very important factor about quantitative imaging, especially if we try to compare CT numbers across different vendor scanners. We know that in single energy world, we cannot do that, or at least the comparison will not be accurate. 120 kV beam on one scanner to the other will not give us the same CT number. But VMI give us very standard independent of acquisition CT numbers. 50 keV is 50 keV, doesn't matter which scanner coming from, they should have the same CT number. So this could be super important for quantitative imaging, radiomics, or AI in our current stage. And just give a quick example, this image we showed before, the PCD already brighter signal, but if we look at the low keV, say 50 keV MI, even more brighter, and we actually, this is really too bright, so we have to change the display window. And now if you adjust window, see those two arrows pointing to two very small structures and show better on the 50 keV compared to standard images. A major benefit of photon counting is high resolution. With the, because we don't have a septa, we can make the detector smaller without lose those efficiency. So the commercial, this is a picture of the commercial photon counting scanner. It can provide 0.2 millimeter slice thickness, ultra high spatial resolution, can benefit in many clinical areas. So this is just a chest case because of the high resolution. You can see much nicer of the lung. And again, there are a lot of studies out there on lung nodules, interstitial lung disease. Similarly, in cardiovascular space, we can see much smaller coronary arteries, and even more impressive if we look at the runoff of the food, see how many more small vessels we can see with photon counting using the high spatial resolution. Stand, coronary stand, about some other stand, with the high resolution, we can see the strut of the individual strut of the stand much nicer with photon counting, and on the EID you basically see a big block of metal there. And not only the metal itself, right, inside the lumen we see them better because with the limited resolution we have so-called blooming artifact that affect us to look at the lumen. And this, if we look at the right images for the clinical case, you can appreciate that too for a renal artery stent case. The high resolution can also help us detect small pieces of stones. Actually, this is the same patient on the EID and the PCD. The EID shows as a big block of stone, but that's just because we don't have resolution to differentiate them. The high resolution PCD shows two pieces of individual stone. More importantly, photon counting gave us the simultaneous high resolution and multi-energy capability. So from the same data set, we can also detect and quantify the stone composition, differentiate different types of stones as the previous speaker demonstrated. So the benefit of the photon counting compared to conventional energy integrating detector is these two benefits coming together simultaneously, single scan. So we don't have registration problem, and also we don't need to pre-select, do I want high resolution, do I want multi-energy? We get everything in just one single scan. So just a quick summary, photon counting directly record individual photons and their associated energy and provide a lot of benefit in many clinical areas. So with the commercial scanner available, and we see also multiple vendors having prototype system doing in vivo patient imaging, we truly believe we are in a new era of CT. So have fun counting photons. Thank you.
Wow, thank you, Shuai. You always make complex concepts so easy to understand. It's my pleasure now to invite Joel Fletcher, who needs no introduction, to speak on photon counting CT in clinical practice.
Thank you. It's an honor and a privilege to be with you here today, and hopefully I can do as good as my distinguished colleagues. So you just heard from Shuai the differences between conventional energy integrating detector and photon counting CT, and I think the big thing for abdominal imaging to emphasize is the increase in iodine signal that we get, because those low energy photons are counted like the high energy photons, and they're not averaged along a very long measurement period that we have with scintillating detectors. So we can really translate these technical advantages of spatial resolution, iodine signal, reduced image noise, and radiation dose efficiency into clinical tasks. And really over the last year, we're beginning to get some real emerging themes for how PCD can help us in patients with abdominal diseases. And the abdomen has been kind of the tough nut to crack, because we don't have as many high contrast tasks as like neuroimaging and chest and musculoskeletal. I'm going to emphasize 5 themes. One, increased iodine signal in multi-energy images can help us in liver and pancreatic imaging. For high-pitch multi-energy scanning can really help us in pediatrics and when scanning for pulmonary embolism. We want to build on what we're seeing in other areas of the body and push the limits of spatial resolution, how it can help our patients. We'll, of course, get the lower radiation dose and image quality that Shuai talked about, and some new exciting work on quantitation that we can do with photon counting CT. So this is very similar to, this is what Shuai showed you earlier, but in patients you can see both of these scans at 120 kV in the same patient. We can really appreciate the increased contrast in these esophageal varices and in the aorta, because those low energy photons are being counted. In this patient with history of uterine cancer, patient was scanned later the same day, and you can see we can really make out that right pelvic sidewall recurrence better despite using only less than half the amount of contrast. And in fact, Dr. Layer and his colleagues have shown that we can get the same image quality and reduce the iodine dose by about 30% at photon counting CT. Now, we can really combine that improved iodine signal with the lower noise that we can get at photon counting CT. So this is the same uncinate process adenocarcinoma, and you can see this is a 1 millimeter slice rather than a 2 millimeter slice. And it's lower noise because we have that higher detector sampling and no electronic noise. Like dual energy, we use the same low energy VMIs that Dr. Dane emphasized. You wonder if there's something here in the pancreas. We can see it better on these 50 keV images confirmed as neuroendocrine neoplasm at dotatate. So with photon counting CT, it's been shown that we have improved image quality of these low energy VMI images. We can have less noise at the same radiation dose. For many medium-sized patients, you get the same image quality, but where photon counting shines is as we move to those larger patients with an overall moderate dose reduction of about 30%. So some important background information is these threshold low images that Dr. Lang talked about are really nearly identical to these 67 to 70 keV VMI images. So those VMI images that are highly reproducible in CT number can be used for your routine recons. So here's an example using some of the principles of dual energy CT This is a metastatic esophageal cancer. Scanned 7 weeks later, you can see the borders of this tumor are much better seen on the 50 keV image. We're finding that we're seeing smaller metastases. This one is identified at CT, subsequent MRI. And last year at RSNA, the Duke group showed in a virtual imaging trial that the benefit for detecting low contrast liver lesions is for the small lesions and at lower doses. And we're finding that in our pancreatic practice, where we do same-day CT and PET MR EVIST enhanced. You can see here this small 6 millimeter metastasis on the hepatobiliary phase, and you can see it over here on the portal phase at CT. Dr. Dane and others have led the recognition for how photon counting can improve our pancreatic imaging. We can see more pancreatic cysts, and we can help visualize small anatomic structures that are inconsistently seen, like the celiac ganglia, as well as side branch ducts. And the NYU group has also shown that it improves reader confidence in looking at pancreatic cancer. So here's an example from our clinical practice, scanned only 7 months apart. You can see there was no mention, you couldn't even see this cyst, which you can make out very well at PCD. And then we can see this side branch duct, which you could follow all the way down to these cystic lesions. The interpretation here was there may be some small cystic foci in the pancreatic head. Down here, 7 months later, it's multifocal side branch IPMN without worrisome features, with a 19 and an 11 millimeter cyst. So a lot more specificity. So you want to be judicious in your protocol utilization, like Al talked about, for dual energy. We do want to take advantage of those thinner slices, but you can see these are all the different types of multi-energy images we can get. You want to be judicious about your use. So you don't have to get every VMI flavor in every plane. So you want to mix and match. And so in our practice, we try to keep a similar number of series. But we do recommend getting the 1 millimeter special spectral images. And these images contain the spectral information that allow you to get these other flavors that you may need for problem solving in your clinical practice. Another theme that we see in other areas of the body, from neuro to runoffs, are that PCD is better at small vessels. So here's an example of fibromuscular dysplasia in our practice. And in fact, we do prostatic embolizations in our practice, and they get routine PCD CTAs to help visualize and shorten the time to recognize where that feeding artery is located. As Shuai showed you, in our vascular practice, we use these sharper kernels so to reduce the metal bloom and better visualize in-stent stenosis. Now, high-pitch multi-energy CT is when the patient is moving so fast through the CT scanner that you're not, with one X-ray tube, you're not covering the whole patient. So you have two, you're utilizing both detectors, and you can go up to a pitch of 3.2, which means that you're scanning the entire abdomen and pelvis in 1 second. And this is used in our pediatric practice, where we do not use anesthesia. And so you can see this is an enterography in a young patient. This is my favorite enterography, courtesy of Kelly Horst. You can see that the improved contrast in the portal vein. You can even make out this rectal cuphitis and the anal sphincters. You can see that occurred with a substantial radiation dose. We also use it in our PE practice. So this is an example from our place where you go from large vessels to small subsegmental pulmonary arteries, and the dark green is good. So you can see that there's less motion artifact as we get to these smaller vessels. And this also emphasizes how good PCD can be in the big patient. This was a 680-pound patient, and we're still getting good quality multi-energy images. As Shuai highlighted, we can see smaller renal stones and this is conventional and photon counting CT. And that can be important in patients in subpopulations of patients with infected stones, certain professions, and patients with chronic flank pain. The other multi-energy images are also generally of higher quality, like the virtual non-contrast. And there are a number of ways to take care of metal artifact, which have been highlighted by the previous speakers. So we're kind of in an area where technology is continuing to change. At this RSNA, we expect a lot of the other manufacturers are working on PCD. We expect those to gain regulatory approval. But at the same time, technology is continuing to evolve. What do we want to do in abdominal CT? So we want to push the boundaries of spatial resolution, particularly for lower contrast tests. So here you can see a T4B rectal cancer invading the sphincters and the levator. Here's a patient with EMVI at MR. On PCD, we could see tumor surrounding that superior hemorrhoidal artery. And then last year, we had the first pilot study using some vendor software that showed that we could accurately measure fat fraction in a small number of patients. And then just recently, a large paper from Rujin Hospital in China was a large prospective study of unenhanced PCD where they got MR proton density fat fractions. And they used a large range of tube potentials at routine and lower dose to show that in a large prospective study of 481 patients that were asymptomatic or had massled, they used a derived formula using these reproducible 70 keV CT number images. And you can see that the interclass correlation coefficient was nearly perfect when compared to the MR-PDFF. In our practice, we're using, we've done some initial work looking at spectral topograms shown earlier in the conference, where we can take that spectral localizer, make hydroxyapatite and water maps using vendor software to create aerial BMD and T-scores. Finally, there's the Society of Abdominal Radiology has created a PCD Emerging Technology Commission led by Drs. Dane and Marin, and that really includes manufacturers, CT physicists, and radiologists. And they've established a common nomenclature that we can use and have many helpful articles for how to introduce PCD into abdominal CT practice. So in conclusion, use of multi-energy information is similar to dual energy images. We want to use those 70 keV or 120 keV threshold low images, and the PCD can be especially helpful at low doses and in large patients. We want to use the high-pitch multi-energy techniques for PE and kids. And think about the improved conspicuity of structures and pathologies for common task. Consider archiving those 1 millimeter special spectral images. Those can be pushed to PACS so that you don't have to rely on a thin client. And there'll be increasing quantitation and collaboration. Thank you.
Thank you very much, JG. Fantastic presentation. I'll be bringing up the last topic, and I do have some disclosures. I do have shares in a company called NextRest. What we've heard about so far are the amazing improvements in technology across photon counting CT, dual energy CT, and how we can use this in clinical practice. A part of CT imaging that's so critical for abdominal imaging is the contrast agents. And I would like to show you, this is a beautiful CT scan that's done today in modern studies. I don't think anyone would criticize this. It would easily pass ACR criteria. And we read these all the time. We don't seem to complain about them. But there are many problems with them. And maybe after the end of the talk, you could look at the scan again and help me identify some of the issues that might be going on with this study. The key is with multi-energy CT, it opens up so many possibilities for not just imaging the soft tissues and bones, but also for imaging future color contrast agents. And this will allow us to have detailed high-resolution multicolor images, true color. And so we've already seen that we can improve the signal of existing iodine contrast. Here, the bowel contrast is not very bright. The blood vessel contrast is not very bright. With a lower KEV, we can brighten up all the contrast and maybe find the less enhancing lesions. This is a mesenteric lymph node that was missed with the regular images and were caught later on with the low KEV images. Another example of ambiguous lesions, Barry Dane already covered these types of topics very well. With the regular CT, it will be very ambiguous which one's a real tumor, which one's not, if anyone is real at all. But with the iodine image, we can see that the renal pelvis lesion is clearly enhancing, and the renal cyst is not enhancing. That was a hyperdense cyst. So our confidence goes up. Our ability to distinguish entities is much better with the multi-energy scan. But a problem that we struggle with regular CT as well as multi-energy is that the contrast agents that we are using were never developed for CT. They were developed for regular plain films and fluoro and not made exactly for our purposes. When we inject the IV contrast, it disappears very quickly like smoke. And for CT, this is a research perfusion scan, we would never do this in regular practice. We can see that the aorta will enhance first, then the smaller arteries, then even smaller arteries, portal vein, hepatic veins enhance at different times. And the peak enhancement of one vessel will occur when the other vessel has already washed out. And so we never get beautiful images of all the vessels, of all the target organs, of all the tumors at the same time. And so we are forced to have trade-offs. So Dr. Fletcher just showed you a study where the pulmonary arteries are not always well opacified. Even with photon counting, there are some that are not well opacified. With studies that are published, 40% to 40% of the blood vessels or studies for PEs are non-diagnostic. Liver vascular enhancement is very variable, even for the same patient on different days. Half of our patients or more don't have their veins well opacified on routine CT scans. Our scan quality is certainly influenced by the contrast material itself. This is a false streaming artifact. It's not a clot, but it was a streaming artifact that was called a thrombus that led to inappropriate treatment of the patient. But with rescanning, it was revealed that it was just a streaming artifact. We only have really one shot on goal. The patient will come into our scanner and get a dose of radiation. They'll get a dose of contrast. What we really want is full, bright, uniform opacification of the entire organ system at the moment of the scan, of the vasculature, the blood vessels of the liver. Can we do better? We have a crack in our road, and the patients are walking on the road. Many patients will get good scans, adequate scans, but depending on the catheter size, the location, whether they have stenoses, some odd cardiac output issue, the injection rate. This is a patient with cardiac issues, and we never got a good scan. The liver is highly variable between scans, and this patient will continuously get suboptimal imaging and fall through the cracks. Potentially, we can do better than this. So if we were to image with iodine, the contrast is very bright in the arteries, not in the veins, just the arteries at a short time after injection, and then quickly dissipates over time, such as at 12 minutes we can barely see it. But if we use some of the newer agents that are in development, this one happens to be a nanoparticle agent based on tantalum, the enhancement will stay. And so even at 12, 15 minutes, the enhancement will be just as bright as on a venous phase. And some of these later time points will have intensities of enhancement very similar to our arterial phase, such that you can actually get all the vessels enhanced and all the organs very, very bright. And this is important because as JG and Barry showed, these very small liver lesions are hard to see. And depending on the paper that we read, the sensitivity of CT may be only 20% or less for these sub 5 millimeter lesions. And so what we have up above is an experimental, not FDA approved, it's not clinically available agent, and we image the subject at at venous phase and then later on delayed time phases. And what I'd like to point out is on the very delayed phases, the detection of this lesion is as good or better than with the best phase for the iodine scan. Here's another example, a very small liver lesion. With the nanoparticle agent, we can see the lesion very, very well, even on a very delayed phase, much better than you could see on the best phase for the iodine scan, given at the same dose of material. And so this is a complicated graph, but what I'll show you is in blue is the nanoparticle agent, and purple is the iodine. And if we take the worst time point, which is very delayed scan, for the nanoparticle agent, it's still much better sensitivity for 3 to 6 millimeter, 7 to 11 millimeter, and even larger liver lesions than the best we could achieve with the iodine imaging. And so the nanoparticle agents that last longer, rather than being dispersed into the interstitium and wasted, the contrast agent is actually doing something that we can visibly see on regular CT as well as on multi-energy CT. Now moving on to oral contrast, it's always a game of roulette because sometimes the oral contrast is so useful to find hypovascular lesions, but then at other times the oral contrast will prevent us from seeing the bowel wall and prevent us from finding the hypervascular lesions, such as neuroendocrine tumors that we saw with Dr. Dane and Dr. Fletcher's presentations. These are a constant problem, and again, we want complete homogeneous bowel filling, but we don't want the material inside the lumen to look like a tumor or to look like blood vessels. And so a new agent being developed by multiple groups in Europe and Asia and America are dark contrast agents. And so we can see this normal air and bowel. This is a scan with a neutral agent. So sometimes there's bowel air. The bowel lumen looks like gallbladder or pus or tumors. But when we have dark material in the lumen, we can distinguish bowel from collections, and also we can see the fine detail of the bowel wall much, much better. And it's been shown that we can pick up small tumors and small lesions of the bowel with less radiation dose and much less ambiguity with these darker agents. And by the way, they're not so dark that they look like air. If you just re-window them a little bit, you can see them because they're not as dark as air. And also they work very well with multi-energy CT. They're easily distinguished by their spectral difference at low and high photon energies. And so, for example, in penetrating trauma, we can use a different type of oral agent than the IV agent. And what's confusing, this is an extravasation, is that bleeding, where the patient needs maybe an IR procedure with embolization, needs to look at the hematocrit carefully, or is this a bowel perforation where the patient needs antibiotics, emergency surgery, bowel resection? It's ambiguous, but now with the dual energy, multi-energy, we can separate the IV contrast, which is one atom, iodine, versus the oral, which is another atom. It could be any number of agents. Again, these are not FDA approved, but the resolution is amazing, and novices that look at the dual energy imaging can easily pick this out and confirm it's bleeding, not a bowel perforation, much better than an expert could looking at a regular scan. So let's go back to the scan. It's a beautiful scan, but what do you see that's wrong? Well, the liver vessels are very unclear. The liver itself is not very bright. We would certainly be at risk of missing small lesions. I cannot even tell the bowel stomach wall from the lumen. It's impossible to tell. They all look like one common. Even with photon counting, it would not be easy to distinguish a bowel lumen because we have positive contrast. This is a tumor, and it was easily missed on a regular scan. Is that a deep venous thrombosis? Very hard to tell. It's not well opacified. Even with multi-energy, it'd be hard to tell. Are these GI bleeding, or is it dense food? It's hard to know. With multi-energy CT, we can improve some of the diagnoses. We can certainly make the liver brighter. We can tell whether something's dense food, maybe, versus GI bleeding. These other entities will need new contrast agents. But if we have new contrast agents, all of these aspects will be improved, and in particular with multi-energy CT. So currently, a minority of our scanners are multi-energy, and even smaller number are photon counting, and these definitely have benefits. But with the new contrast agents, new color agents, we already have the infrastructure to really make our CTs much more diagnostic with more rich information, and even standard CT will become better because we'll have more contrast. smaller vessels. And over time, hopefully everything will then convert to photon counting multi-energy CT. Our target date is 2040. So I thank you very much. And the other thing I'd like to let you know is the voice of radiologists is very important for all industries, whether it's the scanner companies or the contrast agent companies. If you don't speak up, we'll keep getting more of the same. And so it's helpful just to talk to your vendors. And if you want, you can call me or email me. I'm very happy to talk to you about the new technologies coming out and how one can help. Thank you very much. We're at 9 o'clock. I was hoping we had some questions. If anyone has questions, please stay. The speakers can be here. And thank you for your attention.